Welcome to the 2023 Vermont Statewide EMS Protocols Update, Medical EMT. Abdominal pain, adult and pediatric. Please note that due to enough similarities, we have combined the adult and pediatric abdominal pain protocols into one protocol. Allergic reaction anaphylaxis. EMTs have been given several new tools to help patients with acute allergic reaction or anaphylaxis. When administering IM epinephrine, EMTs may now give one repeat dose if signs and symptoms do not resolve in 5 minutes. Contact medical direction for additional dosing. Administration of nebulized albuterol and duoneb were moved from the AEMT to the EMT scope of practice. For bronchospasm, consider the administration of albuterol, 2.5 mg via nebulizer, may repeat every 5 minutes for continued symptoms, or ipratropium 0.5 mg and albuterol 2.5 mg via nebulizer, a duoneb, may repeat every 5 minutes to a maximum of 3 doses. Contact medical direction for additional dosing. EMTs should be sure to review the skills of epinephrine IM injection and nebulizer administration at your home agency. Ready Check Inject RCI instructions were added as a second page of the protocol to provide easier access to this information. Remember, EMTs must be credentialed through RCI to administer epinephrine via a syringe versus via autoinjector. In the Altered Mental Status Protocol, we added clarifying language regarding basic airway management and moved, if patient is violent or agitated, consider restraint, from the paramedic to the EMT section. Although only paramedics can administer medications for chemical restraint, all practitioners may use physical restraints when necessary and should anticipate the potential for violent or combative behavior to a patient who has overdosed on an opioid and is being administered the antidote naloxone. EMTs or AEMTs should call for a paramedic intercept if chemical restraints are required for patient and/or practitioner safety. Please note, in the asthma COPD protocol, we remove the reference to a target oxygen saturation of 89 to 92% for patients with COPD. While it remains true that certain patients with COPD may lose their respiratory drive when high-flow oxygen is applied, this detail was too confusing. The higher priority for patients in respiratory distress is to administer adequate oxygen, and such patients can generally tolerate higher oxygen flows for the duration of 911 transport times. In addition, we removed reference to pandemic situation MDI use in both adult and pediatric asthma protocols. This practice still stands, but will now be found in the pandemic-specific infectious disease protocol. Previously called ALTI, a BRU is an event occurring in an infant less than 1 year of age when an observer reports a sudden, brief, less than 1 minute, but typically less than 20 to 30 seconds, and now resolved episode of greater than or equal to one of the following: cyanosis or pallor, absent, decreased, or irregular breathing, marked change in tone with either hyper or hypotonia, altered level of responsiveness, and a full return to baseline. A BRU should only be diagnosed when there is no alternative explanation for the event after completing a full history and physical. In our BRU protocol, we have added a fingerstick glucose check. Hypoglycemia can lead to transient alteration of mental status consistent with the BRU. More detailed instructions for obtaining a history have also been added, as well as checking for non-accidental trauma. And a red flag which explains that although children who experience BRU have a normal physical exam upon assessment by pre-hospital personnel, they should be transported to the emergency department for further assessment and treatment, as they often have a serious underlying condition. In diabetic emergencies, we have combined the adult and pediatric diabetic emergency protocols for hyperglycemia due to their similarity. Additions to the EMT section include: obtain and transmit a 12-lead ECG for patients greater than or equal to age 40. Obtain an ECG in adults to assess for signs of associated hyper or hypokalemia or myocardial infarction acute coronary syndrome, which can be a cause of DKA. Evaluate for possible sepsis and septic shock. Patients may have hyperglycemia due to underlying infection, including sepsis. A new pearl has been added. If the patient has a continuous glucose monitor, EMS should confirm glucose measurement with their own equipment. We have added a new epistaxis nosebleed protocol. Please review the full protocol. The primary treatment is to apply direct pressure to the bridge of the nose with the head tilted forward, if there's no spinal injury, to help compress nasal vasculature and stop the bleeding. Squeeze the nose or have the patient do so for 10 to 15 minutes continuously. If no evidence of cervical spine injury, tilt the head forward and place patient in position of comfort. Manage bleeding into the posterior pharynx with suctioning. Administer fluids as per the shock protocol. Hyperkalemia and renal failure is another new protocol in 2022. Please review the full protocol. Hyperkalemia is defined as blood potassium levels greater than 5.5 millimoles per liter, with symptoms generally occurring at levels of 6 or more. It is often associated with underlying predisposing conditions such as moderate or severe kidney disease, heart failure, diabetes, or significant tissue trauma. Additionally, medications such as inhibitors of the renin-angiotensin-aldosterone system, potassium-sparing diuretics, non-steroidal anti-inflammatory drugs, succinylcholine, and digitalis may be associated with hyperkalemia. Suspect hyperkalemia in patients with any of these listed findings in history, signs and symptoms, or differential diagnosis, such as dialysis patients with a fistula. Hyperkalemia can cause a range of symptoms from generalized weakness to altered mental status to cardiac dysrhythmias, including bradycardia and cardiac arrest. This slide shows illustrative ECG changes associated with elevated serum potassium concentrations. If you suspect hyperkalemia, obtain and transmit a 12-lead ECG. Repeat the ECG with any change in patient vital signs or presentation. We have established 3 sections in the hypothermia protocol: alert, responsive patients or patients with localized injury, patients with altered mental status or unresponsive patients, and patients in cardiac arrest who are pulseless. Overall, the medicine is unchanged, but reorganization makes the protocol easier to follow. Remember, you are not dead until you are warm and dead. Hypothermic patients should have ongoing CPR and transport to facilities capable of warming with cardiopulmonary bypass or ECMO, even if this means extended transport times with ongoing CPR. Okay, you guessed it, more updates to the nausea and vomiting protocol. It is amazing how much time we always spend on this protocol. There is a lot to unpack here, including new medications and procedures for all practitioner levels. Nausea and vomiting can be a sign of acute coronary syndrome, so we have added instructions to the EMT section of the nausea and vomiting protocol to obtain and transmit a 12-lead ECG if available for patients age greater than or equal to 40. We have also added an evidence-based intervention even EMTs can offer the patient with nausea and vomiting. Isopropyl alcohol. Allow the patient to inhale vapor from isopropyl alcohol wipe 3 times every 15 minutes as tolerated. The mechanism of action is not certain, but it is theorized that isopropyl alcohol influences neurotransmission at several sites that activate the chemoreceptor trigger zone in the brain for vomiting. Opioid overdose continues to be a severe problem in Vermont and nationally. As per existing protocol, for suspected opioid overdose with severe respiratory depression, administer naloxone, also known as Narcan. Instructions to consider restraint of the overdose patient being given naloxone has been moved from the AEMT to the EMT section of both the pediatric and adult protocols. Patients suffering from opioid overdose may become agitated or combative after naloxone administration, and EMS should be prepared for this possibility. Finally, we've added instructions to see the naloxone leave-behind protocol for patients with suspected opioid overdose. We will discuss in more detail later, but in short, the opioid epidemic continues to be a high cause of fatality of Vermonters. Screen patients for opioid use disorder, or OUD, and offer naloxone leave-behind rescue kits and arrange linkage to treatment when possible. Seizures. In both the adult and pediatric seizure protocol, we have removed reference to specific anti-seizure rescue medications and changed the language to read, if anti-seizure rescue medications have been prescribed by the patient's physician and a seizure is lasting greater than 5 minutes, may assist the patient or caregiver with administration by the buccal, oral, rectal, or intranasal route in accordance with the physician's instructions. These new instructions give more treatment options as anti-seizure medications are rapidly changing with new options coming onto market. The adult and pediatric septic shock protocol has had a name change to avoid confusion with other shock protocols. It is now more appropriately called simply sepsis. We've only made a few minor changes to the Unified Northern New England Stroke Protocol. Suspect a possible stroke when any of the following new or sudden symptoms or complaints on this list occur. If you suspect a possible stroke, utilize the pre-hospital stroke screening tool. This is the classic FAST exam, including face, arm, speech, and time last known well. The stroke screen is positive if there is any abnormal finding in facial droop, arm drift, or speech. Remember, EMS stroke assessment is now a two-step process. If the stroke screening scale is positive, the next step is to calculate a stroke severity score using FAST-ED. FAST-ED is used to assess the probability of the stroke being a large vessel occlusion stroke, or LVO. It is critically important to identify possible LVO strokes as different, more effective treatments are available, such as endovascular thrombectomy, but the patient must be triaged to a facility that has the capacity to do this advanced procedure. A FAST-ED score greater than or equal to 4 is considered high probability for an LVO. FAST-ED scores can be calculated manually or by using the Join Triage app that is available for free for EMS. Once you have completed your initial stroke assessment and FAST-ED score, establish stroke alert criteria. Rule out hypoglycemia or other likely causes of altered mental status such as head injury, overdose, or sepsis, and confirm a positive pre-hospital stroke screen, time last known well, and a FAST-ED score. The final step is determination of the most appropriate destination hospital for transport. The one change we have made to the protocol is the removal of the transport time less than 60 minutes guideline, as this number has been variable according to local stroke plans, ranging from 30 to 60 minutes. The protocol now reads, if feasible, transport to endovascular center per your local stroke plan. Additional transport time for diversion to an endovascular stroke center ranges from 30 to 60 minutes depending on your local stroke plan and where you are geographically located in the state. Patients with a positive stroke screen and a FAST-ED score greater than or equal to 4 are at high risk of a large vessel occlusion stroke, and if time last known well is between 4.5 and 24 hours, should be transported to the endovascular center per your local stroke plan. Patients with a positive stroke screen and a FAST-ED score less than 4 are at low risk of a large vessel occlusion and should be transported to the nearest emergency department, as well as patients with a time last known well of less than 4.5 or greater than 24 hours. Work with your regional endovascular center when developing your local stroke plan. If transport time is greater than 60 minutes, transport to the closest emergency department. Here, patients will receive rapid diagnosis, CT, CTA imaging of the head, thrombolytics if indicated, and urgent transfer to an endovascular center for thrombectomy if indicated. Finally, we have added a pearl about posterior circulation stroke, PCS. These types of strokes are usually not identified with most commonly used stroke screens. Most common signs and symptoms include sudden visual deficits, sudden changes in balance and coordination, sudden dizziness or nausea and vomiting. Posterior circulation strokes require prompt treatment and should be evaluated for a stroke alert. Medical direction should be contacted if the patient presents with negative initial stroke screens, but clinical judgment of the EMS practitioner and the presentation are still concerning for a possible stroke. And finally, we have included a new syncope protocol. Syncope is defined as a loss of consciousness accompanied by a loss of postural tone with spontaneous recovery. In near syncope, the patient feels like they are about to pass out, but they do not have an actual loss of consciousness. Syncope must be differentiated from a seizure, which is usually associated with a slower recovery due to the postictal phase. While often thought as benign, syncope can be the sign of a more serious medical emergency. All patients with syncope deserve emergency department evaluation, even if they appear normal with few complaints on scene. Consider all syncope to be of cardiac origin until proven otherwise. Please review the full new syncope protocol. Administer oxygen as appropriate, obtain and transmit a 12-lead ECG. If acute coronary syndrome is suspected, refer to the ACS protocol. Check a blood glucose. Ongoing mental status changes should be treated per the altered mental status protocol. Perform a stroke screening exam, assess for trauma, and consider ALS intercept. This concludes the 2023 Vermont Statewide EMS Protocols Update Medical.